Hi everybody, my name is Rishi Megha. I study at the Indiana University School of Medicine, and I'm currently training at Providence Hospital in Southfield, Michigan. I'm an intern there in general surgery. So, uh, I have nothing to disclose in this talk. And to begin, the choice of mesh in complex ventral hernia repair is a challenge faced by many general surgeons, and the main concern is for surgical site occurrences, which include wound infection, dehiscence, seroma, and other complications like infection. So formally, in an effort to guide preoperative prediction of surgical site occurrences, mesh selection was based on the Ventral Hernia Working Group, and they convened a 4-level grading system that took into account all the different patients' comorbidities. Patients with a grade 2 hernia or above on the 4-level system all received a biologic mesh. And in 2012, Cantors et al. Published a modified 3-level grading scale that predicted surgical site occurrences. Grade 2 patients now included those with comorbidities and previous wound infections, and grade 3 patients to be stratified based on wound contamination. Those with a grade 1 or 2 all received a synthetic mesh from there on out. This resulted in a significantly greater portion of patients receiving synthetic mesh after the transition to the 3-level grading system. And our hypothesis is that we believe that this change had a significant impact on the financial burden of the hospital. Either it increased or decreased the cost, so that's what we wanted to evaluate. So our methods included a retrospective study of 51 complex ventral hernia repair patients. This took place from February 2012 to August 2015 with one general surgeon. The data analysis was performed by developing an outcomes dashboard. This outcomes dashboard was named the IU Surgical Materials Dashboard. It evaluated the ICU length of stay, the overall hospital length of stay, and the overall facility cost per hernia repair. The model was based on our hernia pyramid of success and evaluated with the Six Sigma process improvement scale. So our methods included this hernia pyramid. The hernia pyramid here that I'm showing you states that we evaluated the patients preoperatively, within the OR, postoperatively, and then we looked at our wound recurrence or our mortality and the recurrence rate. And this was all evaluated with the Six Sigma system. The change that we implemented was from the 4-level grading scale to the 3-level grading scale. Therefore, we used this diagram to define our Six Sigma evaluation. We wanted to evaluate the cost, and we measured the total facility cost. Therefore, we analyzed biologic versus synthetic mesh, and we looked at how the 3-level grading system led to improvement, thus what we could control to control costs of the hospital. So our results demonstrated that the implementation of synthetic mesh changed the average length of stay. Within the ICU, patients were there for 3 days less, 6.5 to 3.5. The hospital length of stay was 10.3 to 7.97, and a difference in average facility cost was noted. Biologic was $59,000 per hernia repair, and synthetic was $34,000. Based on our costs, we could see that our dashboard demonstrated an estimated savings of $660,000 annually for all cases of complex hernia repair per surgeon. Therefore, if we extrapolated the costs for more than one surgeon, it can equal well over $1 million of savings. So in our discussion, we understand our sample size was very small. It was 51 patients. Therefore, we suggest a multi-institutional study or meta-analysis to further evaluate how much cost savings can be done. Our key outcomes included, though, $15,000 less per case when used synthetic versus biologic, 3 less ICU days, and 3 less overall days spent in the hospital, cumulatively adding up to roughly $49,000 per month for each general surgeon. So our conclusions state that 3-level hernia grading system results in decreased ICU days and overall length of stay. Furthermore, this 3-level grading system has resulted in a practice shift that has led to more synthetic mesh used in the hospital. And it's clear that the utilization of our institutional database has proven to be reliable to evaluate how we are saving money within the hospital. And finally, our study suggests that the 3-level grading system states that we should continue to use synthetic mesh in complex abdominal wall repair. This may result in potential cost savings that are very significant to every hospital institution. However, our limitation is that we only did it in one hospital with one surgeon. So we suggest that evaluating it on multiple levels at different hospitals, we can truly attain data that's worthy of knowing how much cost savings can be done by using the 3-level system. I just want to thank you all for your time. Have a great day.